My talk would be brief. I will talk very quickly about whether we have a chance to use laser for diabetic macular edema in the anti-VEGF era. I think mostly we covered everything for the treatment of DME. As we all know, DME is the major cause of drop of vision for in the Western population, in the working population. The diabetic macular edema classification was mentioned earlier, whether it is clinically significant macular edema or non-clinically significant macular edema, center or non-center involving, which we depend more on nowadays, and it is dependent on the OCT findings and whether it is ischemic or non-ischemic, and we have the subclinical type, and as well we will not forget whether there is a tractional element or not. So we depended for a long time for the ETDRS classification, whether it is clinically significant macular edema with all the thickening of the retina at or within 500 microns from the center of the fovea, hard exudates at or within 500 microns from the center of the fovea with thickening of the retina. And the last one of them is zone of retinal thickening of 1 disc diameter or larger, any part of which is within 1 disc diameter of the center of the macula. And we depended on the main study, which was the ETDRS, which stated clearly that all eyes with clinically significant macular edema should be treated irrespective of the level of the visual acuity. So even if there is no drop of visual acuity, but we have clinically significant macular edema, we should treat because this reduces the risk of visual loss by 50%. Traditionally thought that macular laser associated with vision stabilization only, but we have some degree of improvement as well. 17% of eyes gained 1 line of vision. And we can see here in the key results and recommendations for the treatment of DME, and we should treat only when it is clinically significant macular edema and not if it is non-clinically significant macular edema. So the question was, and still is in this presentation, was whether we should do laser or not. Retinal laser photocoagulation was first described 45 years ago, and laser for diabetic retinopathy remained the gold standard treatment for the last 3 to 4 decades. We can see the types of laser that we use to do, whether it is grid or focal or modified grid laser, and with the significant thermal effect that we can see. This was at time considered optimum treatment. The edema is gone, the patient is happy, but is it what we want to see in these patients with this positive scotomas and loss of vision in the central part and spillover of the laser on the long term? This is a devastating, definitely, image, but unfortunately it is present, and we can see some of these patients suffering till date. So yes, I would definitely agree with you that this is not the optimum laser that we should do, but still we can see some element of spillover from the laser. We can guide our laser like the Navilas, the navigated laser, or the micropulse laser. But whether, is it a new modality, the micropulse laser? It is not. It is actually described since 1997, and it is not more effective than the conventional thermal or modified ETDRS thermal laser. By multiple studies and review of literature, we cannot really see that it is more effective than the thermal laser. In multiple studies that I reviewed, I didn't find that, yes, it is as effective. Sometimes it reduced the complications of the thermal laser, but it is not of more potency in improving the visual acuity or drying the retina, except in minimal, some studies. I think Dr. Igor maybe will present better studies to show on the effect of the micropulse laser. So the other question that we should answer, are we industry-driven to use the anti-VEGF or to use the steroids for our patients? Have the laser over the last 4 decades have given us the optimum treatment for our patients, and we moved on to use other modalities? The answer, to my knowledge, is no. And the pivotal study that we depend on is the Diabetic Retinopathy Clinical Research Network Protocol I, which evaluated the efficacy and safety of intravitreal ranibizumab plus prompt or deferred laser versus laser. And we can see here the effect and versus the triamcinolone as well. And it showed clearly the improvement in both arms of the ranibizumab in comparison to the laser, and it never picked up the laser except when we introduced the ranibizumab later on in the study. Even the drying effect, despite that we can see that there is some drying effect from the laser, but the vision itself, it did not improve. And this study as well, especially the extension to 5 years, has shown that we will not continue treating these patients indefinitely. We will reduce the number of injections and the number of visits in the years to follow. So starting early the treatment, starting aggressively the treatment will decrease the burden of the treatment later on. Also, we have the RESTORE and the RESTORE extension study, and we keep on seeing the effect of the laser in the bottom of these all studies, like, for example, the RISE and DRIED, the VIVID and VISTA. We can see all that it is ranging in the 1 letter to 2 letter of improvement with the laser arm. So this, to my knowledge, despite some drying effect from the laser, it never showed up to be optimum treatment for our patients. We can use it in certain conditions, and actually this is the treatment evolution that we can see here, and to show all these wonderful drugs that we have nowadays, and we should be using all of them in their possibility. For example, if there is driven by inflammation, we'll use more anti-inflammatory drugs or the anti-VEGF, whether Lucentis or Eylea, and the new drugs available nowadays. So the laser was the gold standard treatment, but nowadays the first and the gold standard treatment, to my knowledge, and I think it is the way forward, is the anti-VEGF and the anti-inflammatory. So what is the recommendation for the treatment of DME? Whether it is non-center involving, we can think of using still the ETDRS recommendations. Center involving with vision drop less than 20/30, we should use anti-VEGF. Then we can consider steroids, whether Ozurdex or Leuven, and we can still use observation for some of our patients if the vision is not dropping. So in my hands nowadays, what I will use laser for? I will use laser for the third entity. If there is retinal edema of 1 disc area or larger, any part of which is within 1 disc diameter from the center of the fovea. So it is non-center involving, and we can see the source of the leakage. That's the time that I will use laser for. And to conclude the treatment of DME, anti-VEGF is the new gold standard treatment. Steroid implants could be used in resistant cases or as an adjuvant during the treatment course. Laser still plays a role, especially in non-center involving DME, according to the ETDRS protocol. And thank you for attending. Thanks a lot.